Well, so today we shall discuss about management of HIV in normal patients, as well as we shall discuss two important topics, that is prevention of parent to child transfer and prevention and what is the post exposure prophylaxis of the HIV, which are very commonly asked in the theory as well as viva. So I am Dr. Abhishek Ghosh, Assistant Professor of Pharmacology, Community of Medicine, JNM Hospital, Kalyani. So today, the first topic we shall discuss what is the normal regime for the HIV patients. So nowadays it is actually according to the NACO guideline, that is the National AIDS Control Organization guideline, and it says that whenever we are detecting presence of the HIV, we should start treatment immediately rather than staging for the AIDS. And we have different drug class. We have nucleoside reverse transcriptase inhibitor like lamivudine, zidovudine, tenofovir, etc. Tenofovir, though it is a nucleotide reverse transcriptase inhibitor. We have non-nucleoside reverse transcriptase inhibitor like efavirenz, nevirapine. We have protease inhibitor like indinavir, lopinavir, ritonavir, etc. We have integrase inhibitor like dolutegravir, raltegravir. We have CCR5 receptor antagonists that are like maraviroc, and we have also entry inhibitor, that is enfovetide. Now, what is the first line ARV regime? ARV means antiretroviral regime guidance. So, ART regime, normally we use this TLE regime nowadays, tenofovir, lamivudine, efavirenz. And you have to remember the dose also. It is easy to remember. Tenofovir 300 mg once a day, lamivudine 300 mg once a day, and efavirenz 600 mg once a day. 300, 300, 600. So, it is the first line ART regime for all, provided patient's age should be more than 10 years and body weight should be less than is more than 30 kg. Below 10 years and or below 30 kg, it is not advised to use this regime. So what we can use, and also it should be tenofovir should be used cautiously in the patients of the renal impairment. So alternative regime is abacavir, lamivudine, efavirenz. So here abacavir is replacing the tenofovir, and it is the first line ART regime for all patients with abnormal serum creatinine value. So when creatinine value is above normal range, we should not use tenofovir. We can use abacavir in its place. And all adults and adolescents with body weight less than 30 kg also we use abacavir. So body weight less than 30 kg or patient's age less than 10 years, and also creatinine clearance little bit, if it is high, then we use abacavir. We do not use tenofovir. Next, another regime we can use, especially in consideration of when we are suspecting HIV 1 and 2 co-infection or alone HIV 2 infection. We use their protease inhibitor, not the NNRTI, efavirenz. Okay, there we use tenofovir, lamivudine plus lopinavir, ritonavir. So lopinavir, ritonavir is used as a protease inhibitor. So it is the first line ART regime for all, especially in all women with the single dose nevirapine exposure in a past pregnancy. So what is that? Does that mean? So nevirapine is used during the pregnancy for the prevention of mother to child transfer of the HIV. But if woman has received nevirapine during past pregnancy, after that we use this, we cannot use nevirapine because there is chance of nevirapine resistance. So lopinavir, ritonavir is used in its place. And also all confirmed cases of HIV 2 or HIV 1 and 2 co-infection, then it is better to use this protease inhibitor, lopinavir, ritonavir, not the efavirenz. Okay. And suppose, so these are the actually newer regime, but if some older patients are already on some older regime and if they are stable, then we can use some older regime also. So all patients who are on either of the first line regimes initiated earlier in the program need to be continued on the same regime unless failing. So if treatment is failing, then we can switch over to therapy, but if patient is stable, doing well, then we can continue previous regime like zidovudine, lamivudine, nevirapine, and zidovudine, lamivudine, efavirenz, anyone. So these are the example of the regime of the drug where actually two NRTI are combined with either one NRTI or protease inhibitor. So protease inhibitor we use slovitamide, ritonavir. Actually this is an augmented regime. Here actually lopinavir is used as a metabolism inhibitor which inhibits the metabolism of ritonavir, so that ritonavir can be used in relatively lower dose, thus can prevent the toxicity of the ritonavir. Okay. So what to monitor? We can monitor the body weight, treatment adherence, clinical monitoring and T staging, and also you have to screen for the tuberculosis. We have to monitor the CD4 cell count. CD4 has to be done every 6 months. Viral load should be measured after initiation 6 months, 12 months and then every 12 months. So CD4 count is done as and when routine virological monitoring becomes available. It should be done every 6 months till CD4 count reaches greater than 350 cells per cubic millimeter and viral load is less than 1000 copies per ml. So when CD4 count should be high, our goal of treatment is CD4 count should be high and viral load should be low. So when both tests are conducted at the same time, viral load should be less than 1000 and CD4 count should be more than 350 cells per cubic millimeter. Till then we have to monitor it frequently, and after that we can monitor every 12 months. So CD4 monitoring should be restarted for any patient if the patient has suspected treatment failure. So what is treatment failure? If the viral load is more than 1000 copies per ml, or if the patient has undergone a switch in the regime, or if the treatment is changed due to any reason, maybe due to drug toxicity or poor adherence, etc. And prevention of parent to child transmission. So this is the regime for the Haart, H-A-R-T, that is highly active antiretroviral therapy. Though in them that you are using 2 NRTI plus 1 NRTI or 2 PI. So prevention of parent to child transmission, which is also very commonly asked short note, you have to remember it very well. So what is the risk of HIV transmission from mother to child with antiretroviral interventions? Look here, there are different percentage has been revealed from the different studies. So if a mother is on have HIV but she is not on antiretroviral therapy yet and she is breastfeeding, risk of HIV transmission is very high, 30 to 45%. No ARV, no breastfeeding, risk is 20 to 25%. Short course of 1 ARV, breastfeeding, 15 to 25% is risk. Short course with 1 ARV, no breastfeeding, still there is 5 to 15% risk. Short course with 2 ARV, breastfeeding 5%. But now we know that three drugs should be given in an antiretroviral therapy. So if patient is on 3 ARV antiretroviral drug with breastfeeding, still risk is 2%, and with no breastfeeding still risk is 1%. It is not 0. So though in different Western worlds actually mother with HIV do not are not allowed to breastfeed, but actually in India NACO guideline says that for this just 1% risk reduction, we should not deny the advantage of the breast milk to the infant. So that's why mother should continue the HIV antiretroviral therapy and she can breastfeed to the infant, because there are immense benefit of the breast milk, and for the 1% risk reduction of the HIV transmission, we should not stop breastfeeding to the infant. And what is the regime? Once again, the national guideline, National AIDS Control Organization program, it is recommended to provide lifelong ART for all. ART means antiretroviral therapy for all pregnant and breastfeeding women living with HIV, in which all pregnant women should receive single pill triple drug regime, that is the lamivudine, tenofovir, efavirenz. Once again, that tenofovir, lamivudine 300 and efavirenz 600 mg, regardless of the CD4 count or clinical stage of AIDS, both for their own health and to prevent vertical HIV transmission, that means from transmission from mother to child, and for additional HIV prevention benefits. Okay, so this is the treatment regime for the Pptct or PMTCT. Both can come as short note. Pptct means prevention of parent to child transfer, but nowadays more scientific term is PMCT, that is prevention of mother to child transfer. Remember, if short note comes, answer will be same. And ARV for the pregnant woman and exposed infant. So what is the guideline says? All HIV positive pregnant women, including those presenting in labor and breastfeeding, should be initiated on a triple drug ART regardless of the CD4 count and clinical stage, and for preventing mother to child transmission and continue the lifelong ART. Now it is the regime for the mother, but we have to give some preventive measures to the infant also or neonate also, and it is guideline says that we should give nevirapine prophylaxis to the infant, even if he is not HIV negative. If he is HIV positive, unfortunately, but then we have to give the normal 3-drug antiretroviral regime. But even if he is HIV negative, born from a pregnant mother, then nevirapine prophylaxis should be given. How long it should be continued? That depends on the how long mother has taken the HIV drug or antiretroviral drug before delivery. So duration of nevirapine prophylaxis to the HIV exposed infant should be minimum of 6 weeks. However, the duration of nevirapine prophylaxis should be extended to 12 weeks if the duration of ART in pregnant mother falls short 4 weeks before pregnancy. That means if mother has received antiretroviral regime more than 4 weeks before delivery, before labor, then she can then infant should be given nevirapine prophylaxis for 6 weeks. But if it is less than 4 weeks so if mother has taken HIV drug, antiretroviral drug for less than 4 weeks or maybe started just before the labor, then nevirapine prophylaxis should be continued to 12 weeks. Okay, so this duration you have to remember. Okay, and also there are multiple approaches which can prevent the mother to child transfer. Primary prevention of HIV, especially among the women of childbearing age, prevention of the unintended pregnancy among the women living with HIV, prevention of the HIV transmission from pregnant women infected with HIV to their children, and provide care, support and treatment to women living with HIV and to their children and families. So what are the additional measures apart from the drug? So remember the drug regime, tenofovir, lamivudine, efavirenz to the mother, it should be continued lifelong, and infant should receive nevirapine. That depends on 6 weeks or 12 weeks, depending on how long mother has taken the antiretroviral drug before delivery. If mother has taken less than 4 weeks, then it should be nevirapine prophylaxis should be prolonged in the infant. That means 12 weeks. If mother has taken antiretroviral therapy for more than 4 weeks before delivery, then we can stop the nevirapine prophylaxis in 6 weeks. But remember, provided infant should be HIV negative. If infant is HIV positive, then standard antiretroviral regime should be started in the infant also. So apart from this drug, we can have to some other intervention during labor and delivery, like minimization of the vaginal examination, avoid prolonged labor, consider oxytocin to shorten labor, avoid artificial rupture of the membrane. Cord clamping should be done early after it stops pulsating and after giving the mother oxytocin. Use non-invasive fetal monitoring, like we can avoid the invasive procedure, avoid routine episiotomy, minimize the use of forceps or vacuum extractors. And in India, normal vaginal delivery is recommended unless woman has specific obstetric indications for the delivery, cesarean section. Okay, so like fetal distress, obstetric labor. So vaginal delivery can be a safe approach. Cesarean section is not mandatory for the HIV patients, but use of ART can reduce the risk of Pptct better and with lesser risk than a C-section. That means C-section is cesarean section. That means it says that we should start ART as early as possible when we are detecting a mother with HIV positive. That actually minimizes the risk better than doing the cesarean section only. So whenever suppose we are detecting a mother of HIV in first time during the labor, we should start ART immediately. Then we can decide about the mode of delivery. So only using the cesarean section will not be so much effective. Rather, we should start at least HIV antiretroviral therapy. Then we can decide about the mode of delivery, and there is no significant difference between the cesarean section and the vaginal delivery. ART in pregnant and breastfeeding women. So all breastfeeding and pregnant women, they can be given that same regime, tenofovir, lamivudine, efavirenz, 300 milligram, to be given 2 hours after low fat or fat free dinner, and that regime can be continued during the breastfeeding also. Okay, and if they have received already on the 014, continue the same regime. ART regime for pregnant women receiving prior exposure to NNRTI for Pptct. That means it is if mother is previously has received the efavirenz, now she is pregnant second time, or in previous pregnancy she has received efavirenz or nevirapine, now she is pregnant again. Now we cannot use nevirapine or efavirenz again. Then we have to use lopinavir, ritonavir as protease inhibitor, because repeat pregnancy, that nevirapine, efavirenz, it is seen that there is more chance of resistance against those NNRTI. That's why you should use protease inhibitor, tenofovir, lamivudine plus protease inhibitor, lopinavir, ritonavir. Okay, here dose of lopinavir, ritonavir is 200 milligram. Lopinavir, ritonavir is 50 milligram, 2 tablets twice daily. Okay, and as per Pptct guideline, all positive pregnant women exposed to nevirapine, efavirenz in past should be initiated on the lopinavir, ritonavir, that is protease inhibitor regime instead of the efavirenz. Okay, and abacavir can be given for all patients with whom there is some renal impairment or who develop toxicity to tenofovir. So once again, those 3 regimes. So we have to remember actually 3 regimes for the adults, mainly tenofovir, lamivudine plus efavirenz, that is standard regime. Tenofovir should be avoided in presence of renal impairment, so we can give abacavir then. Also we can give abacavir when patient's body weight is less than 30 kg or less than 10 years age. For mother, it is abacavir can be given only when there is renal impairment, and in the patients who have received nevirapine, efavirenz during past pregnancy, if she is pregnant again, then we can switch over to the lopinavir, ritonavir regime in place of efavirenz. And also it should be considered when there is HIV-2 is detected. Okay, so pregnant women presenting active labor, So often it is found that women who have not routinely done their antenatal checkup regularly, often they are detected with HIV during the labor. So as soon as possible, we have to start this TLE regime, that is the tenofovir diamifluprednate efavirenz regime, and we should continue it postpartum also. And nevirapine prophylaxis for the infants should be for 12 weeks, as mother did not receive any ART during the antenatal period. Okay. The infant should be started on nevirapine. Duration of nevirapine prophylaxis I have mentioned 6 weeks or 12 weeks. So daily infant nevirapine prophylaxis can be started even if more than 72 hours have been passed since birth and should continue. During this period, mother should be linked to the appropriate ART service. And duration of therapy I have mentioned 6 weeks or 12 weeks. But if suppose it is the decision of the mother whether she should breastfeed or not, it is recommended to do breastfeeding. But if some mother chooses not to breastfeed, then nevirapine prophylaxis can be stopped within 6 weeks. But if mother is breastfeeding, as breastfeeding has that 1% chance, 2% chance, and no breastfeeding still has 1% chance. So for that reason, it is recommended that we should continue the nevirapine for 12 weeks, even if the mother is breastfeeding. Okay, so this point should be remembered. So the recommended ARV prophylaxis for HIV exposed infants. So the nevirapine dose, it is mentioned that if body weight size of the infant is less than 2 kg, nevirapine daily dose should be 2 mg per kg once daily. And if body weight is normal, that is 2.5 kg or more, nevirapine dose should be 15 mg once a day. And if it is in between, it can be 10 mg to 10 mg once a day. That means body weight 2 kg to 2.5 kg, nevirapine daily dose should be 10 mg once a day. These are the toxicity regime. Toxicity, we know all that nevirapine. So nevirapine or efavirenz can cause skin rash, hepatitis, skin manifestation, CNS manifestation. Tenofovir overall safe, but it can cause some renal toxicity. It can elevate the serum creatinine. And 014 lamivudine, they can cause mitochondrial toxicity like lactic acidosis, pancreatitis, lipodystrophy, peripheral neuropathy, anemia, as well as myopathy. So this is the definition of the ART failure. ART failure means plasma viral load above 1000 copies per ml. Or immunological failure means falling CD4 cell count, that means it can fall below baseline, or persistent CD4 level below 100 cells per cubic millimeter, or 50% fall from an on treatment peak level. So suppose it is not fall to 100, but suppose during the treatment actually patients sometime has a CD4 count was 400, but now it is below 200, then it is also called immunological failure. And clinical failure means new or recurrent clinical event indicating severe immunodeficiency, WHO clinical staging 4 condition after 6 months of the effective treatment, that is also called clinical failure. That means we have to change the therapy, not existing therapy should be discontinued. Okay. So we have, whenever there is treatment failure, we have to give another regime, like we can give integrase inhibitor, dolutegravir, daltegravir, or we can switch over to the protease inhibitor based regime. Next, post-exposure prophylaxis. That is very important, actually most commonly asked question, and we have to be very much familiar with this regime and when to give which drug. So exposure means which may place an healthcare professional at risk of bloodborne infection. It is defined as a percutaneous injury, contact with a mucous membrane of the eye or mouth, contact with the non-intact skin, and contact with intact skin when the duration of contact is prolonged with blood or other potentially infectious body fluids. It can be occupational exposure or non-occupational exposure. And PEP, actually post-exposure prophylaxis, refers to the comprehensive management instituted to minimize the risk of infection following potential exposure to bloodborne pathogens. It can be against HIV, hepatitis B, and hepatitis C virus. So who are at the risk? Professionals with high chance of blood exposure is nursing staff, emergency care providers, delivery room personnel, surgeons, operating OT staff, physicians, lab technicians, as well as interns, dentists, and also health facility cleaning staff, mortuary staff, clinical waste handlers. So what is the regime and whom to give? With those universal precautions is that they are intended to prevent the exposure of healthcare workers and patients to bloodborne pathogens. There must be practice in regard to the blood and body fluids of all patients, regardless of their infection status. And universal precautions include hand washing before and after all medical procedures, safe handling and immediate safe disposal of the sharps, not recapping needles, using special containers for sharp disposal, like using needle cutter and destroyers, using forceps instead of fingers for guiding the sutures, and safe decontamination of the instruments, use of protective barriers whenever indicated to prevent the direct contact with the blood, as well as other body fluids such as gloves, masks, goggles, aprons, boots should be used. A healthcare professional who has a cut or abrasion should cover the wound before providing the care. Safe disposal of the contaminated waste is also mandatory. So now there are some categories of exposure and category of the uh, source. So source code and exposure code. There are two. Source means patient from which there is risk of transmission of the HIV, and exposure means what is the level of the exposure. So mild exposure means exposure to mucous membrane or non-intact skin with small volumes. Example, a superficial wound with a plain or low caliber needle, or contact with eye or mucous membrane, subcutaneous injection following small bore needles, etc. Moderate exposure means exposure to the mucous membrane or non-intact skin with large volume. So small volume non-intact skin is mild exposure, small volume, a large volume non-intact skin is moderate exposure, also exposure to mucous membrane, and also it can be percutaneous superficial exposure with solid needle, like cut or needle stick injury, penetrating gloves. So suppose patient is doctor is wearing gloves, but still there is a percutaneous injury, that is called moderate exposure. And severe exposure means percutaneous exposure with large volume. So small volume percutaneous injury is moderate exposure. Large volume percutaneous injury is severe exposure. It can be by high caliber needle more than 18 gauge, visibly contaminated with blood, or a deep wound, hemorrhagic wound, or very painful wound, transfusion of the significant volume of the blood, or an accident with the material that has previously been used intravenously or intraarterially in the source patient, HIV patient. Okay. In case of any in case of this exposure with materials such as discarded sharps, needles contaminated for 4 weeks, 48 hours, the risk of infection becomes negligible for HIV, but still remains significant for the hepatitis B virus. Okay, because hepatitis B survives longer than the HIV outside the body. And this is the source category. HIV negative or HIV low risk is the source risk is very negligible, it is 0. Low risk means HIV positive and clinically asymptomatic, and high risk means HIV positive and clinically symptomatic. Now look here, this you have to write in exam HIV exposure code and also source code. So whether the material is the blood or any body fluid or potentially infected material or instrument contaminated with one of these substance. If it is yes, then what type of exposure occurred? If it is no, then no PAP required. So if it is not blood or any bloody fluid or any instrument, then PAP is not required. If it is yes, then what type of exposure? As I mentioned, mucous membrane or skin integrity compromised, then we have to think about the large volume or small volume. If it is small, so if skin integrity is intact, and if it is non intact, that means non intact skin means damaged skin as well as mucous membrane. If it is small volume, then it is EC1, exposure code 1. If it is large volume, then it is EC2. If intact skin, then of course there is no risk of HIV transmission, then no PEP is required. So second point is, look here, intact skin, no PEP required, but non-intact skin, small volume means EC1, large volume, non-intact skin or mucous membrane, it is EC2. And percutaneous exposure, small volume, it is EC2, large volume, percutaneous exposure, it is EC3. Okay, it's very easy to understand. So no non-intact skin, no PEP required. If there is no exposure to any body fluid like blood or potentially infected material or instrument, then it is not needed. If it is mucous membrane or non-intact skin exposure, small volume, it is EC1, large volume EC2, percutaneous exposure, small volume EC2, percutaneous exposure, large volume EC3. Okay. Next, source code. So HIV negative patient, no PEP is required. HIV positive patient whose CD4 count is high, asymptomatic clinically, and viral load is also low, then source code 1. High titer exposure, advanced disease in the patient, low CD4 count, HIV source code 2. Okay, and sometimes we do not know the source, then it is called unknown. Next, so when PEP is required, so NACO recommends PEP for healthcare professional based on the exposure and HIV source code. So exposure code 1, source code 1, PEP is not warranted. Whenever there is anything is more than 1, then we have to give PEP. So 1, 2, 1 exposure code, so source code 2, 2 exposure code, source code 1, or both are 2, either one of these 3 or 1 or 2, then of course we have to give PEP. Okay, and PEP should be started as soon as possible, preferably within 72 hours, and it should be continued for 28 days. Okay, so only when exposure code 1 and source code 1, then PEP is not warranted. But whenever it is more, some is more than 1, then you have, of course, you have to give PEP. And regime for PEP, and remember, this is for the accidental exposure, and this sexual assault also comes under this. So for in case of sexual assault, PEP should be given to the exposed person as a part of the overall package to the post sexual assault care. Now what is the regime? So we know here actually main aim is to cover both HIV 1 and 2. That's why though previously TLE regime was used, now the guideline says that you should use TL plus tenofovir lamivudine plus lopinavir ritonavir, because if efavirenz or nevirapine will not provide you protection against the HIV-2 virus. So we do not know the source code always, what is the category of the HIV 1 or 2 patient is suffering. So to cover HIV 1 and 2, it is better to provide the regime of PEP by tenofovir 300, lamivudine 300 mg once a daily, plus lopinavir 200 mg and ritonavir 50 mg, 2 tablet twice daily, and both should be continued for 4 weeks. Okay, so tenofovir lamivudine fixed dose combination 300 once a day, lopinavir ritonavir fixed dose combination 2 tablet twice a day. Okay, and if lopinavir ritonavir is not available or cannot be used, then only we can use efavirenz in its place. But remember, efavirenz will not provide you protection against the HIV-2. Okay, so in case of highly treatment experienced source, to initiate first dose as per the above guidelines, and expert opinion should be sought urgently by the phone or email from the ART Plus Center. So this is the regime you have to remember for the PEP regime. Okay, so this is the short notes which we can expect from HIV, Haart, antiretroviral therapy, post-exposure prophylaxis, and also prevention of mother to child transfer or prevention of parent to child transfer. So prepare this, it will be very much essential for your medical course as well during internship also, and also during examination. Okay.